Can I welcome everybody to the annual review of NHS Health Scotland. As you know, the annual review by definition takes place every year, and the purpose of it is to, through these various meetings that we've had this morning and another meeting later on after this session, is to help us hold the board and the senior management team in particular of NHS Health Scotland to account in terms of the work they're doing, making sure that they're performing according to plan, and to look forward as well. So it's a bit of, as they say in Latin, respici prospici, look backward and look forward. And the way in which we're doing this, we've changed the format somewhat since last year. So I've already met the partnership board this morning. I've met a number of people involved in key areas of work as well. We then have this open public session, and then after that I have a meeting with the board to discuss various issues that may or may not be of concern. So the main part of this session is a presentation led by Margaret Burns, the chair of NHS Scotland, and that will be about 10-12 minutes or so. And then we'll move from that into a more open session in terms of questions and so on. So can I hand over, well, first of all, I should have introduced everybody. We're missing Donald Henderson, who should be sitting there. And Donald's the Deputy Director of the Public Health Division in St Andrews House. On my immediate left, no reflection on his politics, is John Conahan, Acting Director of the Scottish Health and Social Care Directorate and Chief Executive of NHS Scotland, myself, Alec Neil, Cabinet Secretary, Margaret, and Jerry McLaughlin, Chief Executive of NHS Scotland. So can I hand over to Margaret for a presentation?
Thank you very much, Cabinet Secretary. And on behalf of NHS Health Scotland, I'd like to welcome you and John and Donald to our offices, and to welcome the audience here. We're very pleased to have you here to account for how we performed in 2012-13 and to reflect with you on what the challenges are to come. We set out our role very clearly in 2012 in our 5-year strategy, A Fairer, Healthier Scotland. We have a very clear focus on one of the biggest health challenges facing Scotland, our enduring and growing health inequalities gap. For the benefit of all of us in the room, health inequalities means those differences in health, those unfair differences in health that are suffered by different groups and individuals, differences that are avoidable. There are different ways of describing it, but this is one that's particularly stark, and I know you're familiar with it, Cabinet Secretary, because we're looking at it at the NHS event in June. This is a map of the train system in Glasgow, with Jordan Hill on the west, Bridgeton in the east. Every stop on that green line represents a 2-year reduction in life expectancy. This shows you a difference in life expectancy. So a man in Jordan Hill has a life expectancy of about 76. When you get to Bridgeton, it's about 62. And that's just one way you can describe it. It's very stark. Last week at a Voluntary Health Scotland conference, somebody put it that health inequalities mean that people are sicker longer and die younger. Again, I think that's a way of encapsulating it. There's two key things about health inequalities, that it isn't just about the health service and what the health service does. It is about the social determinants of health. That's a jargon phrase. And what it means is that your health and health inequalities are about the circumstances in which you're born, grow up, live, work and age. That determines your health. Another point is that health inequalities don't come on their own, that they're inextricably linked to and caused by other fundamental inequalities: power, money, resources. So our mission, which we set out in A Fairer, Healthier Scotland, is there. It's about reducing health inequalities and improving health by influencing policy and practice informed by evidence, and promoting action across the public services to deliver greater equality and improved health for all in Scotland. Now, we are part of the health service in Scotland, your health service in Scotland, and we are working towards the 2020 vision for health in Scotland, which is that everyone is able to live longer, healthier lives at home or in a homely setting. And it's the everyone that's crucially important to our work. We are committed to improving everyone's health, but we know that when we're doing that, we have to pay particular attention to people who are coping with the worst of health inequalities. Just to make that a bit more concrete, we know that stopping smoking can have the biggest health impact for people. We know that smoking is much more prevalent in deprived areas. And we know that people who live in disadvantaged circumstances find it more difficult to stop smoking. So we have to be looking at how people get fair access to services. Everyone gets fair access to services. The evidence also tells us that you're more likely to help people to stop smoking if you also tackle some of the other difficulties they're facing. So we might be looking at integrating smoking cessation services with income maximisation, employability as well. So that, again, I think gives you a flavour about that. It's about improving everyone's health, but bringing particular attention to the people who are in most need of help. As part of the NHS and the 2020 vision, our role is quite clearly identified in the route map that we're all following in the NHS, because it talks about health inequalities, about prevention, we're very much about prevention, the public service reform agenda, and about shifting the balance of power to individuals and communities and using their assets, and the need to work with other partners, particularly local partners. That's clearly where we sit in that part of the health service that's driving forward action across the piece. And along with everyone else in the NHS, we're committed to the quality ambitions that what we do is safe, it's effective, and particularly person-centred, so that everyone can achieve optimal health. It's about everyone. So for our account for the year in 2012-13, I don't want to sound complacent, but I do want to tell you that we performed well. We delivered our local delivery plan and our business plan. We met all of our financial targets, including our efficiency savings targets. Now, a big bit of our work is supporting local territorial health boards to deliver the health improvement HEAT targets. And you'll know, Cabinet Secretary, that the NHS Scotland performed well on those targets in 2012-13 across the range of the health improvement HEAT targets in child oral health, child healthy weight, cardiovascular health, smoking cessation and sexual health. We've got a good story to tell, and we contributed to that. We also made good progress in all the actions that were identified at our last annual review. The details are in the self-assessment, and happy to answer questions. In summary, we can show we're prioritising health inequalities. We have undertaken a range of work on the impact of welfare reform, and I'll say a wee bit more about that later. We have continued to focus on the impact on health and health inequalities of alcohol overconsumption, and we are working collaboratively with community planning partners. Some of the internal actions, last year we were asked about bullying and harassment, and we've continued to work on that in partnership systematically. And we've sought to engage with our staff in matters that affect them and in how we implement a fairer, healthier Scotland. Our staff absence rate for the year is 3.03%, which is better than the HEAT standard. As of the end of March, it was only something like about 70% of our staff had personal development plans, but we've made a really concerted effort there, and I'm really pleased to be able to tell you that as of now, 93% of our staff have personal development plans, and 90% have had a knowledge and skills review in the last 12 months. And I hope that demonstrates our commitment to our staff. I'd like to take this opportunity to pay tribute to the staff of Health Scotland. It's been a year of change for them. We're consolidating our offices from 5 to 2. We've got a new business improvement programme to improve ways of working so we're smarter and as efficient as possible, and we're implementing this new strategy. The staff of Health Scotland have met these challenges and still delivered excellent work, and you'll have seen some of that in the showcases. The staff of Health Scotland are very expert, and also, and I'm sure you'll have seen that in the showcase work as well, they're very expert at collaborative working, partnership working. I hope that came across. They are a resource for the NHS and for the whole of Scotland that I think we can all be justly proud with. They're recognised nationally and internationally for the work that they do. Last year's annual review, we had a stakeholder panel. We had we had a chief executive of a health board, someone from a local authority, with Dean Davidson from the CBI, with someone from the voluntary sector and public health, and they put us through our paces. And at the end of that, they said, right, if we were doing this next year, we'd be saying, you'll have had your transition year then, let's see how you're delivering on your new strategy. And I would like to say that, again, to tell you that we've made good progress in starting to deliver on our new strategy, on better policy, better practice and stronger support for action. You'll have seen, Cabinet Secretary, this morning in our showcase, just for the benefit of the audience, we were looking at our evaluation of the alcohol strategy, the work that the Choose Life team are doing on suicide prevention, and on how we're working with community planning partnerships. And these are all some areas of work. And there's other details in the self-assessment. For me, I'd just like to pick out 3 highlights. One, as you'll know, your colleague Michael Matheson, the Minister for Public Health, is a task force on tackling health inequalities, of which I'm a member. We were commissioned by the task force to produce a policy review on health inequalities. What does the evidence tell us about what works and what doesn't? We've produced that review, and it's an excellent basis for all of us to think about what we need to do, what actions we need to take. We've also made a significant contribution with others on welfare reform and the impact of welfare reform. Along with others, we've produced a report on what are the likely health impacts of welfare reform and how they affect different groups differently. And it will be a differential impact. Of course, the headline message for all of us is that so many people will just get less money, people who are already amongst the poorest. And we have to be concerned about the impact of that on health inequalities. And we will be tracking how that manifests itself. At the same time, we worked with the Directors of Public Health to produce a guide for health boards. Well, what can they do to mitigate some of the implications of welfare reform? That report's been published. It's basically about looking at how you maximise income, how you look at employment opportunities, employability, and also how you might think about tackling the stigma that attaches to folk who claim benefit these days. There's also, as part of the website for the Scottish Public Health Network, boards have been asked to post up what they've been doing locally so that other people can get ideas and work on that. And I know that's close to your heart, but how we spread the good practice, and there's some really good examples on that website for people. Lastly, looking at how we help people taking decisions locally. The year before last, we produced a guide for local authority councillors on health inequalities. What are they? How can you get data for your area? What can you do? We are presently producing a guide for non-executive members of health boards along the same lines, and we're hoping that that will be equally as successful. So these are just some of my highlights for the year. And then just very briefly, what we think the challenges are for the future. It's about being efficient and effective. We met all of our efficiency savings this year not by doing less, but by working smarter and more efficiently. And the challenge is to keep doing that. We will meet our efficiency targets, but we want to do that in the right way. The other thing that you'll have got a sense of is working with different partners out with the health service, local authorities, all of the local partnerships that we see, the third sector. We're starting to work with people like Shelter and Oxfam as well. So we're working with a range of different partners. And lastly, and I think the overarching challenge for us is that health inequality is a priority, so that everybody in the NHS, local authorities and other stakeholders know about health inequalities, see it as a priority and know what they can do and the action that they can take, and that we are supporting them to do that. So I think that's what we see as the overarching challenge for us. So, over to you.
Great, thank you very much indeed. I'll maybe ask some questions later and John will, but before we do that, can I open it up to anyone in the audience who has a question or would like to make a comment? I'll get someone up there. If you could give your name, please, that would be helpful. And if you can stand up, could you get a mobile mic? Unlike me, I've got a static one down here. Can you stand up so we can see you?
I'll stand up.
Right, good.
I've got a lot of things on my desk. So, on my lap. So, hello, thank you for that. My name's Claire Tester. I'm strategic lead for third sector engagement in health and well-being, working with the Scottish Government and also with yourselves. And I just would like to ask that we know that reducing health inequalities is integral to the work of the third sector. And I wonder if you would share something of how you're working at Health Scotland with the third sector in prevention and early action.
I'll hand over to Jeremy. I think we are, how I'd say is we're starting to do that. We are working with a range of different partners like Shelter and other groups. We have a public engagement group to look at that, about how we engage with them strategically. But I think we're at the start of that, about how we do that better. so that we can support the voluntary sector in terms of their understanding of health inequalities and what they can do. So I can think of some examples of where we've been working with the health sector. For example, 2 weeks ago we supported shelters housing on homelessness and health. It's just one example. But I think we're starting to do that. That describes that. I don't know, Jerry, if you wanted to add to that.
Yes, I'm happy to. I think throughout the life of Health Scotland, we've always had a fairly active engagement with the voluntary sector. What I would say is that a lot of that work, though, has been on quite specific topic areas of our work. So that might be around tobacco, or it might be around mental health, or it might be around alcohol, or work with drug and alcohol partnerships. We've always had, though, a core relationship with 2 or 3 quite significant voluntary organisations within the health field, and particularly within the community health field and voluntary health field. What I think we looked at when we developed our new organisational strategy with a focus on how we would reduce health inequalities in Scotland was that we needed to really take a look at how strategically we engaged with the third sector around what the contribution across all of public services would be. And I think in that regard, Margaret's mentioned some of the work that we've been doing with Shelter. We've also been doing some quite effective work with the Poverty Alliance, particularly around the welfare reform agenda, in order to position us and allow us, first of all, to have our work informed by the broadest possible perspective, from organisations who are working both with and on behalf of local communities in Scotland. And that's a dimension that we certainly believe that we can strengthen within Health Scotland. We also have been looking for other opportunities to make sure that we engage effectively and ensure that health inequalities as a main policy objective is right at the heart of other voluntary sector interests. And we've recently been invited from by colleagues within the third sector unit within Scottish Government and a number of third sector organisations within Scotland to take part in a further round table to examine exactly that question, and we are currently planning with colleagues on that event.
Okay. Any other questions or comments? Put up your hand. No? Nobody else? Can I ask Margaret and Jerry, one of the issues I know that the Health Committee in the Parliament have mentioned, although they haven't actually done any inquiry into it, is that if you did an analysis of the people who use the health service the most, it will tend to be people in the higher income groups. As income goes up, they make greater use of the health service. The chair of the committee calls them, the convener of the committee calls them the worried well, or the worried wealthy, or wealthier. And at the other end of the spectrum, people in the deep end practices, for example, tell me that the health check program's not being used at all by the very people who it's targeted at, because these people do not make the kind of contact regularly with the health service that they should, or that wealthier people do. So are you doing any work to look at strategies where we can better tailor and manage demand to meet need? Because we're very demand-led, I think, rather than need-led.
I agree with you. It's they call it the inverse care law, that the folk that need the most help actually get less. Again, I'll pass over to Jerry, but I do think working with the deep end practices, and that's one of the priorities under the route map to the 2020 vision, and finding out from them what more could be done, I think would be very important. I think at the base of that, one of our key messages is about health impact, inequalities impact assessment, so that people delivering services actually ask themselves, who is it that's accessing them, and is everybody getting fair access to services? So I think everyone who's involved in delivering services needs to be asking those questions in a systematic way and then addressing the questions, and we're certainly helping a lot of people with health inequalities impact assessment, not as a paper exercise, but so that you actually do different things at the end of it.
Jay?
And so, Cabinet Secretary, I think this is quite a complex picture because a lot of our service demand actually comes from the very communities that we are seeking to serve. And I think if we look at, particularly, you spoke earlier on today around the percentage of Scots who live with long-term conditions. One of the things that we know is that entry into many of our acute services are from that very group, and therefore some of our most deprived communities actually make very good use of NHS services. What I think we would like to do is to shape that service to ensure that it was focused much more on what would prevent the deterioration of individual health conditions and require acute care, so that many more people could be living longer and healthier lives supported in their own homes. So I think at that level, actually we've probably got quite a good representation, maybe a representation we would not particularly seek in relation to access to those services. What I think we're clear about though, and of course all public organisations have a legal duty to assess their services to make sure they are able to be accessed by all groups, and one of the things that we've been doing is a lot of work, as Margaret says, to help the system, help the service ensure that they are designing their service in a way that's most likely to allow them to be accessed by people who quite often don't. A colleague, Judith Robertson from Oxfam, last week used a term that I was very attracted to. This group is often defined as a hard-to-reach group. She said, no, they're not hard to reach, they're easy to ignore. And I think we're doing a lot of work both in ensuring, first of all, that the products and services that we develop are most likely to meet the groups that we want to, and to support colleagues across territorial boards in designing services that have that impact. Okay. John?
Can I just follow this up, but maybe from a different perspective, and from the perspective of community planning partnerships? You mentioned some of this earlier, and there have been a number of studies, including the Audit Scotland one, which really made us take a look at how effective CPPs were in this area. So it would be useful if you could say a little bit more about what you're doing with CPPs. How can we make them more effective in terms of tackling inequalities? And could you give us one or two practical examples of where you've really made a difference?
Right. I'll make a start, and ask her to get in as well. I know that the Minister and the Director General will have seen some of this earlier. We have been providing information for all of the community planning partnership, just in providing basic information and community health profiles. What does your population look like in terms of health inequalities? So we provide that basic data, which is a starting point. We've also been working with some community planning partnerships to help them plan effectively for joint outcomes. I think one of the things that came out of looking at the single outcome agreements was it's still the case in many areas where folk are just got their own plans and they kind of stitch them together at the edges. Whereas what we really all want to see is real joint planning towards outcomes. So we're helping some community planning partnerships to actually do joint planning towards outcomes. I don't know if you'd like to add to that, Jerry.
So if I was to take a very practical example, I had the privilege of being involved in a process that was looking at all of the new single outcome agreements that were being developed by partnerships earlier in this year, and where the council leaders and government wanted to assure themselves of the quality of those plans. And let me pick out an example that maybe illustrates what you've asked, John. So in one of those outcome agreements, I was looking at an authority that was actually doing quite well around breastfeeding rates. What was very clear was that they had an ambition to improve breastfeeding rates within their area. But if I looked at the data available for within that local authority area, they ranged from 17% in one part of the authority to 42%. And the CPP set itself an objective of improving that rate by a further 1%. My question in the discussion that we had with the CPP would be, what action are you taking to try and significantly tackle that 17% and move that up, so that we have in the gradient, we actually have an adjustment of the gradient, rather than simply achieve that 1% improvement by improving the rate at which it was already amongst Scotland's best. So that maybe give you an example. And of course, in relation to breastfeeding, it is not simply a health intervention that's going to create the opportunity and create the circumstances in which you're likely to improve breastfeeding rates. You asked about a very specific example, and we've been doing a lot of work in supporting a Scotland-wide approach to suicide prevention. We've all been extremely concerned about the level of our suicide rate within Scotland, and the fact that suicide claims more lives in Scotland than road traffic accidents, fires at home, put together So it's a major issue, and one that the government has been focused on for some years. I'm delighted to say that the approach taken, and we've played a significant part nationally in trying to support this work, has shown in recent years a reduction in the suicide rate of 18%, and I think it's a very practical example. So by bringing staff together, by ensuring that we are helping support other partners within public services in training and developing their own workforce to spot the risk signs of suicide, including 50% of GPs reached through this learning and development. I think that gives a very practical example of the contribution that Health Scotland's making in a very real way.
Okay, thank you. Donald?
You've been doing a lot of work on helping people to understand the underlying causes of health inequalities at the same time as continuing your work on short and medium-term measures to address them. Where do you see the balance lying between the long-term versus the short to medium? Are you at that balance yet, or are you still a way to go towards it?
I don't think we're talking about a balance. It's our view we need to be doing both. We need to, because that's where the evidence takes us. We know that health inequalities don't just sit there on their own. They are fundamentally caused by these other inequalities. We all know that and feel that. So we need to, continue to, to make that case. Not least because what tends to happen in the past is people talk about health inequalities and recognise it, but then what you actually do is only to focus on people's own behaviour. Now, we know that will not work. We know that. The evidence tells us that. So we do always have to keep focusing on the fundamental causes. But at the same time, we do have to, people are here now and they need help and support, and we have this aim of improving everyone to get to optimal health. So I don't think we're ever going to get to a balance about that. I think we'll always be going to be doing both.
Can I ask, have you done any work on, the so-called nudge strategies, which I know the Prime Minister's a fan of, but somebody needs to nudge him sometimes. But in terms of, for example, we did, I think, some pilots years ago in terms of smoking, I think it was in Dundee, about incentives to pregnant mums, about, there's an incentive, a financial incentive, not to smoke. Now, I think that particular one had mixed success, but is there more scope for maybe doing, you mentioned breastfeeding, for example, Jerry, but is there more scope for adopting a nudge strategy, or is it just one of these wheezes that costs a lot of money and doesn't achieve much?
Can I, before Jerry, my Director of Public Health Science there is saying the nudge approach as described by the Prime Minister doesn't work.
Well,
we know
there's
that.
a lot of things the Prime Minister describes, doesn't he?
And I'm not allowed to be political, I'm just saying what the evidence tells us. So we don't do that in Scotland. In Scotland, the sorts of things that you're talking about is I think, a different thing. That's looking about the circumstances in which people lead their lives and what is it likely to be most helpful and influential. So that's, I wouldn't describe that as nudge because we know that doesn't work, but that's what we...
Carrot and stick, put it that way. Is there room for more of a carrot and stick?
I certainly think there's room for us using what the evidence tells us is likely to work. And for example, we've used the evidence around focusing our smoking cessation services in a very particular way. We know if we do them generally, we will get good quit rates. But if we want to really focus on the groups where we are most concerned about health in Scotland and addressing that inequalities gap, then we can't do that in a very generic way. So we need to tailor our smoking cessation services. So a good example of this, Cabinet Secretary, would be we contributed to some work that has fed now through into the quality maternity strategy. And you'll be aware that we are now adopting an approach where all newly pregnant mums are going to be screened for carbon monoxide. Now, that's a very good example of following where the evidence takes you, because if you simply expect people always to opt in, people who are most savvy, most knowledgeable about their health will be the ones that will most opt in. If you introduce a service that's more universal, like screening, we will have much more chance of picking up and then creating that opportunity that all of those healthcare interventions give us to actually have meaningful conversations with new mums about what support they require to stop smoking. So I might put it less in the carrot and stick mode, and to say, actually, the evidence tells us if we tailor our services effectively, they can have maximum impact. And just returning briefly to Donald's point earlier on, I think it is a blend. I think it's a blend of us ensuring that we support service delivery to get maximum access and to make sure people who need services most are getting top quality services. And I think it's very clear that the quality strategy absolutely addresses that. You've heard a little bit about our work across public services in the third sector around how we then ensure that one agency is never going to crack this. We've got to have a very different approach about thinking about prevention, as Campbell Christie so eloquently told us. But also, we need to know that some of the drivers for this are absolutely fundamental, and you alluded to this morning. And we need to show that that's what the evidence tells us. And therefore, that at times will mean longer term planning around legislative measures, around potentially fiscal measures that will produce different outcomes. So I think it is a blend of all three of those approaches.
The Director of Public Health, Andrew, is here. So I don't know if you want to add anything to that, Andrew?
On the nudge issue specifically?
Well, any of it.
Oh, thank you very much indeed. Well, on the nudge issue, there has been a lot of interest in it. The evidence is lacking that it has an effect on health inequalities. It's one thing to suggest an intervention, but it's another thing to quiz people on their current behaviour, much in the style of alcohol brief interventions or other brief interventions. That has something going for it, but just to suggest an area in the vague expectation that people would take it up and change their behaviour is not going to be sufficient.
Okay, great, thank you. Any other questions or comments from the floor? This is one of the quietest annual reviews I've ever done. Okay, Maggie, do you want to sum up from your side, please?
Just to thank you again, Cabinet Secretary, for the chance for us to display what we can do. I mean, I think Health Scotland performs well and is this resource for the NHS and for Scotland. With the staff, we will be that organisation that will drive forward in health inequalities.
Okay. And can I just thank Margaret and Jerry and the team for all the excellent work they've done in the last year, and say look forward to working with you in the year to come. I know that the relocation has been a bit controversial, but hopefully that once that happens, people will be able to settle down and continue the excellent work that's been ongoing. Some of this work, in fact all of the work is very important, but some of it obviously is of major importance, particularly I think minimum unit pricing. I'm absolutely convinced that when we introduce it will have a transformational impact on health in Scotland. And we now have the Irish government following our example, we have the Estonian government following our example, and I think there will be many other governments with very similar problems to the ones we have in Scotland follow the example. There's very clearly a pattern within the European Union in terms of government policies on minimum unit pricing, and that is that almost every health ministry is absolutely in favour of it, and the people who are against it are the finance ministries. I personally think that's a very, very short-sighted approach, because if you look at the economics of minimum unit pricing, the cost of the damage to health and the wider cost to society, I think, far exceed any revenue implications for adopting the policy. They certainly do in Scotland, which is why we've got a united cabinet, including John Swinney, the Finance Secretary, who are very, very keen to see the implementation of minimum unit pricing. Similarly, I saw this morning a presentation on suicide prevention, and suicides in Scotland have gone down by about 18% in recent years. I think probably that figure also underestimates the impact of the programme, because the real question is how many more suicides would there have been without the impact of the programme. And I suspect that the reduction is, in terms of potential suicides, is a lot higher than 18%, and also the work on providing support not just to health but to other agencies in community planning partnerships. John Swinney is leading the reform programme on community planning partnerships, and again it's an area where I think we can improve at local level the importance of joined up government. An example of where that's working well in a number of areas is in data, using data much more effectively, to mine data, to collect data more effectively, to share data between agencies. And very often we find that the families who are the ones involved with the education department, say around truancy, are very often the same families who have got some relationship with the criminal justice system. And very often they're the families who are least likely to tap into the resources of the National Health Service and so on and so forth. And very often they're the families who've got the poorest standard of living or the lowest income, most dependent on benefits, very often in their area. So sharing data between agencies is very important because it allows us to make the kind of preventive interventions on a joint basis that would not be possible without sharing that data. And that's part and parcel of a wider strategy at local and national level of trying to ensure that all the agencies work much more cohesively together and do so on a preventive strategy rather than waiting till the damage is done and then trying to pick up the pieces. And I think that has to be the whole thrust of what we're doing in the National Health Service, but in the wider public sector in Scotland. And obviously NHS Health makes an enormous contribution, not just to that in terms of the National Health Service, but more widely in terms of the contribution to assisting the wider public sector agenda. So can I thank Margaret and Jerry and their team and congratulate you on your successes in the last year, and I look forward to seeing you in a less cramped room, I hope, next year. So thank you very much indeed.
Thank you.